Good morning. We're about to begin. Raise your hand if you're able to hear me clearly. All right, that's good enough. All right, this morning we'll be starting with patient assessment. And as time allows, we'll be covering trauma as well. All right, now in any area of medicine that involves interacting with people and doing some level of assessment or and skills or treatment, it will involve some level of assessment. So there is a sequential way to assess and manage a patient, and each profession has a specific way of assessing the patient. So nurses do it a particular way, doctors do it a particular way, and EMS responders do it in a particular way as well. EMRs are the first trained EMS providers at many emergency scenes, and you will be the first person to interact with the patient, and that interaction will involve an assessment. Now, the patient assessment algorithm or sequence in EMS has 5 main parts. So we need to be able to perform a scene size up, perform a primary assessment, obtain relevant information on the patient's history, perform a secondary assessment, and reassessment. So there are 5 main parts. Within each area of the patient assessment sequence, there are things that must be considered and there are things that must be done. So in scene size up, we need to consider certain things and we need to do certain things. Same thing for primary assessment and the other areas. The skills and knowledge presented in the chapter follow an assessment-based care model. The treatment rendered is based on the patient's symptoms. Assessment-based care requires you to conduct a careful and thorough evaluation. And what this means is we cannot manage something that we have not properly assessed. So the assessment comes before treatment, not treatment, then assessment. Patient assessment sequence. So let's go through the sequence now. The patient assessment sequence provides a framework so that you can safely approach an emergency scene, determine the need for additional help, examine the patient to determine if injuries or illnesses are present. You will be required to obtain the patient's medical history and report the results to other EMS personnel when they arrive on location and you need to hand over. Now, the first part of the sequence, patient assessment sequence, is a scene size up. This is a general overview of the incident and its surroundings. You will process the information that you receive from dispatch. So that information can include the location of the incident, the main problem or type of incident, the number of people, and the safety level of the scene. Other factors can affect your actions: the time of day, day of the week, weather condition. Is it morning? Is it night? It's night. We have to think about visibility. Is it day? You can have a lot of traffic on the road during the days. You can have a lot of traffic on the road during the night as well, depending on the location. Weather conditions. If you are excessively hot in that environment, the patient will be excessively hot. If you are excessively cold, patient will be cold as well. Mentally prepare for other situations you may find when you arrive on the scene. If you come across a medical emergency, contact dispatch using your two-way radio. Right, so some service use the radio, some will have a phone that you can call, but in first world response is going to be a radio dispatch system. Now, the first thing that we need to do is ensure that the scene is safe for us, our crew, patient, and bystanders, in that order. So it's safety of yourself, your crew, the patient, bystanders. So ensure the scene is safe. Park your vehicle so that it helps secure the scene and minimize traffic blockage. Scan the scene and determine the extent of the incident, the possible number of people, and the presence of possible hazards. Go ahead, Mr. Walker. Not hearing you. Still not hearing you. If something is wrong with your mic, type in the chat. All right. So we need to determine the extent of the incident, the possible number of people injured, and whether or not there are hazards present. All right, now visible hazards: crash or crime scenes, fallen electrical wires, traffic, spilled gasoline, unstable buildings or surfaces, weather, crowd. Now, if it is a motor vehicle accident scene, law enforcement will be necessary for that location, and the fire department will be necessary as well. If it's a down power line, then before you can approach the patient, if that power line is on a vehicle, the power company needs to be contacted to kill the power in that line before you can make contact with the patient. So the principle is, if something is present that can make the scene unsafe or not safe for you and your crew, then you need to request the relevant resources to make that scene safe so that you can do what you need to do. If it's a crime scene and we are the first to arrive on that location, if police is not present, matter of fact, we are not allowed to respond to that location unless we get clearance from law enforcement, right? So usually what occurs if it's a crime scene, potential crime scene, the law enforcement is dispatched to the location. They will secure the scene. Once the scene is secured, they will clear EMS to enter the location. Law enforcement is also responsible for crowd control. If there is chemicals or gas exposure, hazardous materials. Usually, when you have multiple patients or persons presenting with similar signs and symptoms, that's hazardous material. We need to be so far away from that scene that we need a binoculars to see the location. So if it's a hazardous material incident or hazmat incident, a hazmat team, and usually it's a part of the fire service, will go to that location and they will secure the scene and designate what is called the hot, warm, and cold zone. The hot zone is where the exposure is at its highest concentration. The warm zone is where the patient is decontaminated, and the cold zone is where EMS will be waiting on the patient. So again, the rule is if something is present on the location that will make that scene not safe for you and your crew to work effectively, we need to request the resources that is required to make that scene safe. And one of the most unpredictable hazards on a scene, especially in Jamaica, I'm not talking about first world response, no, I'm talking about specifically Jamaica, is going to be the crowd. So crowd is very unpredictable here because of the lack of awareness and public education. They can make it very difficult to respond. No. Continuing with hazards, electricity, biological hazards, hazardous material, poisonous fumes, and these are things that we can't see. If a scene is unsafe, keep people away until specially trained teams arrive. Right? Again, the scene is not safe, do not approach the patient. And it may mean that you stay at a distance until the relevant resources is present, and that may result in the patient might not surviving, right? So that patient might not survive based on the length of time that the available resources takes to get to that location. That is a reality. But we do not put our personal lives and the safety of our crew members at risk under no circumstances. All right, so the first thing that we need to consider in the scene size up is the safety of the scene, and the scene will always be dynamic. So it's something that constantly changes. I have to be anticipating that. The next thing that we need to consider in the scene size up is we need to determine the mechanism of injury or nature of illness. The mechanism of injury is whatever caused the injury to the patient. And when we talk about injury or trauma, trauma results from forces applied to the body. So that is what causes trauma. If force is applied to the body and the body is not able to dissipate that force, the force becomes more concentrated, and that results in soft tissue injury or traumatic injuries. So the mechanism of injury is whatever generated that force. Was it a fall? Was the patient shot or stabbed? Was the patient hit by a car? Whatever caused the injury. And that injury can be diffused or it can be localized. So the mechanism of injury can be specific to a point of the body. Person was hit with a baseball bat on the forearm. That is localized, so it's specific to the forearm. Or it can be diffuse. The patient drop out on a mango tree more than 15 feet. If it's diffuse, then the possibility for multiple trauma exists for the patient. Now, this is what is important from this concept. If it is a localized injury, we focus on the point of injury. If it is a diffused mechanism where the possibility for multiple trauma exists, we focus on the entire patient and we approach that patient as if the patient has a spinal injury. I will repeat that. If the mechanism is localized, specific to an area of the body, we focus on the specific area. So if it's a leg, focus on the leg. If the mechanism is diffused and the possibility for multiple trauma exists, we focus on the entire patient and we approach that patient as if the patient has spinal injury until it is ruled out in a hospital setting. So that's the mechanism of injury. The nature of illness is specific to medical patients. So this is the patient's chief complaint. What is the patient complaining of? Right? That's the nature of illness. Is it shortness of breath? Is it chest pain? Is it abdominal pain? Is it a severe headache with nausea and vomiting? What is the patient complaining of? Now, with the nature of illness, you can get that information directly from the patient. So you can get that information by communicating directly with the patient. You can get it from family members, you can get it from bystanders, and you can get it from the location or scene, the environment that you find the patient in. Right? So determine the mechanism of injury or nature of illness. Look for clues that may indicate how the accident happened. Ask the patient, family members, or bystanders for additional information. Do not rule out any injury without conducting a full body physical assessment. Right? So first thing in the scene size up that we consider, the safety of the scene. Is the scene safe? We consider the mechanism of injury or nature of illness. We take the necessary standard precautions, right? So we take the necessary standard precautions. That's it. Excuse me. Always have gloves readily available. So at minimum, you must always have on your gloves. Always. Consider whether the use of additional protection may be necessary. If we have to manage a patient's airway, it is important to cover the eyes, nose, and mouth. If we're in a situation where there's a lot of body fluids and blood involved, then it would be appropriate to wear a gown at that point. And with the current COVID situation, most COVID protocol is full gown with face mask and goggles. So standard precautions, always have gloves readily available. Consider whether the use of additional protection may be necessary. Wash your hands thoroughly after contact with a patient or contaminated materials. All right, so 1, scene safe. 2, what is the mechanism of injury for trauma? what is the nature of illness for medical patients. We take standard precautions for ourselves and our crew members, and we determine the number of patients. So you need to determine how many patients are present. Now, if multiple patients are on that location and you are the first responder to arrive on that location, your goal is going to be to request additional resources and initiate triage. So you're going to be responsible for starting triage. Triage means to sort patients. It does not mean to treat. And we need to understand that concept clearly. So triage means to sort patients based on their priority, right? So if you have multiple patients on a location and it exceeds your available resources, you now have a mass casualty situation. And your goal is to request additional resources and start the triage process. Now, what does that really mean? It means if I have, let's say I arrive on a scene, a motor vehicle accident, multiple car collisions, multiple patients injured, and I arrive on that scene. The very first patient, the patient that is closest to me, right? The patient that is closest to me has a limb that's amputated. No, not the patient closest to me. The patient that is at the back, right? So patient number 15. When I look down the line, I see him crawl out and one of his limb has been amputated, right? That's patient number 15. I'm not gonna run past 1 to 14 and go to patient 15 to administer care. That's not how triage works. Triage will start with the first patient I come in contact with. And before I make contact with any patient, I'm gonna go on my microphone and I'm going to speak to them, right? Hello, my name is Ryan Rufus. I'm a paramedic with MedStar. This is Unit 20. There are other units on their way to provide assistance. If anybody can hear my voice and you're able to get up and walk, I want you to move to my right. So go to my right on the sidewalk over there. So anybody who is able to get up or move around, that's your walking wounded. So I just triage a whole heap of people. Then I will start where I stand. So the first patient that I make contact with, I will triage. And the triage process is different from assessment, right? So that's what it means to triage patient. And by doing that process, doing it that way, I may very well get to patient 15, and when I reach patient 15, he's not alive. That can happen. The goal of triage is not to utilize all your resources for one patient. It is to save as many patients as possible. So you're sorting patients based on their priority. And when units arrive, they will transport these patients based on the color code that you put on the patient. That's how triage works. Ensure that that's understood. So determine the number of patients and whether or not you need additional resources. Consider additional resources, and these are the additional resources that may be required. Law enforcement personnel or the police force, fire department, utility companies, wrecker operators, right? And that would be the scene size up phase of the patient assessment sequence. So 1, ensure the scene is safe. 2, what is the MOI or NOI? Take the necessary standard precautions. How many patients you have? Do you need additional resources? Now, before I move into the primary assessment, are there any questions at this point? All right.
Yes.
Go ahead.
Can you, Marlene, can you repeat the scene size up order again? You said ensure the scene is safe.
Right. So 1, ensure the scene is safe. It doesn't have to be in that
Order, I
particular
know.
order, but 1, ensure the scene is safe. That's the most important one.
Mm-hmm.
Make sure the scene is safe. 2, consider the mechanism of injury or nature of illness. 3, ensure that you have the appropriate standard precautions. At minimum, must have your gloves on before you make contact with a patient. 4, how many patients do you have? So determine the number of patients that are present. And if you have multiple patients, do you need additional resources? Right? And the last one would be you consider additional resources and request whichever one that is needed. You got that?
Yes.
All right, good. And remember, crowd in Jamaica is very unpredictable. So never allow a crowd to encircle you with a patient, right? If that happens, you have a blind side. So never allow a crowd to encircle you. Also, never allow someone that is behaving aggressive or hostile towards you to breach your striking distance, right? And your striking distance is the extension of your arm. So never allow somebody that's aggressive to get within your striking distance, and never allow them to square up with you, right? Now, you can be in a situation where somebody is being aggressive and they breach your striking distance. That's your arm's length. If your striking distance is breached, under no circumstances should your hands be below your waist, right? Because if your hands below your waist, you're not able to react to anything defensively. And I will go into a little more detail with that when we get in the class setting, right? So don't allow people that are aggressive to get within your striking distance. Don't allow them to square up with you. And if they breach your striking distance, your hands need to be up. And you can have your hands up above your waist and it's in a passive position, right? And this is something I develop or practice because of my martial arts background and when I was working as a correctional officer. So I never allowed a prisoner to get within my striking distance, and if they were, my hands were always above my waist to react appropriately. But we can explore that in the face-to-face session. No, not Kung Fu. I don't do Kung Fu. All right. The next phase of the patient assessment sequence is the primary assessment. And this is very important. This is a very important section. Reason why the primary assessment is so important is because This is where you make contact with the patient. So this is where you're going to interact with the patient. This is where you're going to look for things that can kill the patient quickly and address them. And the main purpose of the primary assessment is to identify life threats to the patient and address these life threats. When you have a patient in an emergency situation, and when I say emergency, I'm talking about life and death circumstances. Three things can kill a patient very fast. And these three things must be assessed and ruled out. So one, if your patient's airway is closed, they're going to, that can kill them very quickly. So if the patient's airway is not patent or open, can kill the patient very fast. Two, a patient in which their chest is not moving, right? So they're in respiratory arrest. If the patient's chest is not moving, that can kill the patient very quickly. Three, a patient who is bleeding excessively. So if the patient is bleeding excessively and it's not controlled, they're going to bleed to death. So these are things that you should always keep in the back of your mind, right? And these are things that we want to rule out quick. Is this patient airway open? Is the chest moving? Do I see blood loss? Is it excessive, right? Now, just like the scene size up, there are things that must be considered and there are things that must be done. For the primary assessment, there are things that we need to sequentially execute. So the first thing is we need to form a general impression of the patient and the environment that you find the patient in. The general impression is a visual assessment, right? So you're doing a visual assessment on the patient and your goal is to answer two questions when you do this visual assessment. One, does the patient look sick or injured? So that's the first thing. Does this patient look sick or injured to me? If the answer to that question is yes, how sick or injured is this patient? Is there a life-threatening problem present? Do I need to address it before I do anything else? So that's the two questions we need to answer. Does the patient look sick or injured? If yes, how sick or injured is this patient? Is it a life and death situation, right? So your former general impression of the patient and the environment. Note the patient's sex and approximate age. So is it a male or a female? Right? And as time go by, we might have to consider some other things in that, but time will tell. Right? So is it, for now, is it a male or a female or in between? Right? The approximate age is not important. So I don't want you to go out there and look at a person and say, okay, this person look like him about 35. No, don't go out there and do that. You will find out the patient's exact age based on questions that you ask or by looking on some form of identification. The approximate age at this point is not important. What you're trying to determine at this point is which category would you put the patient in? Is this an adult? Does this patient look like an adult? Does it look like a pediatric patient or a child? Does it look like a geriatric patient or an elderly patient? Right? So that's what I need to find out at that point. It will guide my approach to assessment and management. So if it's an adult, I would be thinking about typical presentation, typical presentation. If it's a geriatric or elderly patient, I'm thinking about a typical presentation because the systems don't function the same anymore. If it's a pediatric patient, I'm thinking about airway, right? They have a lot of complications with their airway based on the anatomy, or their airway anatomy is structured. And when pediatric patients go into cardiac arrest, it's because of an airway problem. So that is what kills pediatric patients, airway issues. So that's what you really want to determine where the age is concerned. Determine whether the patient has experienced trauma or illness. That might not always be clear. It might be in some cases, but it might not always be clear at that point. So don't develop tunnel vision. If your assessment is thorough, you will be able to determine if your patient has a traumatic issue or a medical problem. And just keep in mind that a patient can have a combination of both. So a patient can be up on his roof doing some painting and get a stroke and drop off of the roof and get traumatic injuries, right? The patient can meet in a car accident and fracture his leg, and a clot gets into his venous system and give him a pulmonary embolism. So that's a trauma that caused a medical problem. So they can have a combination of both. Just ensure that your assessment is thorough. Determine the patient's level of consciousness. We went through that yesterday. So assess the patient's level of responsiveness. Introduce yourself to establish your reason for being at the scene. Hello, ma'am. Hello, sir. My name is Mr. Rufus. I'm a medic. This is my partner, so-and-so. We're here to assist. What's your name? Can you tell us what's happening to you? Right, so, excuse me. Introduce yourself to establish your reason for being at the scene, the fact that you will be helping the patient, and the patient's level of consciousness. Introduce yourself even if the patient appears to be unconscious. So a patient can be unconscious and they can still hear you. So always communicate with the patient, especially if the patient is talking to you. Because if you are communicating with a patient that's talking to you, you'll know when the patient stopped talking. Pretty straightforward. So assess the patient's level of responsiveness using the AVPU scale, right? So alert, you check for alertness. And let's say you enter a room. So you enter a room, the patient is sitting in a couch. You approach a patient. Hello, sir. My name is so-and-so. This is my partner. What's your name? Patient said, my name is John Doe. Okay, Mr. Doe. How can we assist you today? What's going on? Why, you know, say, did I come out of the bathroom and slip? Catch my balance, but I think I twist my knee. I'm having a lot of pain in my left knee. All right, now based on Mr. Doe interaction with me, he's alert, right? So that would be an alert patient. He's following me in the environment. He's interacting with me appropriately, right? That's an alert patient. Let's say we enter the room again, right? We enter the room. The patient is lying in bed, the eyes are not open, you approach a patient. Hello, sir. You don't get a response from the patient. Hello, hello, sir. Can you hear me? My name is so-and-so. This is my partner. We're here to help. And the patient, when you said that, the patient opened his eyes and moans. Open him eye and he moan. That patient is responding to verbal stimuli. So he's responding to verbal stimuli. He's not fully alert. Same patient. You enter the room. Patient is in the bed. You approach a patient. Hello, sir. Can you hear me? My name is Ryan Rufus. I'm a medic. This is my partner, so-and-so. We're here to help. Can you hear me? You don't get any response. Sir, you tap him shoulder. Sir, can you hear me? He doesn't respond. You apply pain, right? So you apply a painful stimuli. When you apply that painful stimuli, the patient groans. Patient is responding to pain. And the areas for the painful stimuli is the supraorbital nerve. I will show you when we're in the classroom setting where that would be. You can pinch the neck. You can twist the ear. And you can put pressure on the cuticle of the nail. Don't worry about it. We will cover this in the classroom setting. The one to me that is least effective is twisting the ear. I don't think twisting the ear hurts that much. And my go-to is the pressure on the supraorbital nerve. That's the nerve just above the ridge of the eye, at the ridge of the eye, and the pressure on the cuticle. I prefer these methods because I don't have to use a lot of pressure to get a painful response. But as I said, we'll go through it in class when we have the mannequin. No. So the patient is responding to pain if they respond to a painful stimuli. Same patient is on the bed. You approach the patient. Sir, can you hear me? Doesn't respond. So-and-so, I'm here to help. Can you hear me? No response. You apply pain. Patient doesn't respond to pain. Your patient is now fully unresponsive. So you have determined that your patient is fully unresponsive. Very important now. Once you determine that your patient is fully unresponsive, you need to be thinking about airway management, because we learned this yesterday. When a patient is unresponsive, the muscles that control the tongue relax and the tongue falls back into the ear passage. It can either completely obstruct the airway or partially obstruct the airway. If it's partial, you hear snoring. So there is something that we need to rectify if the patient is unresponsive. So that's the AVPU scale. You check for alertness, verbal stimuli, painful stimuli, unresponsive. Perform a rapid scan. So assess, once we have determined the patient's level of consciousness, we need to assess and manage the upper airway if necessary. If the patient is alert and able to answer questions, the airway is open. In an unconscious patient, you must open the airway. And the two methods that you have for that, or required to use for that particular task, I should say, is the head tilt, chin lift if there is no spinal injury, suspicion of spinal injury, or the jaw thrust maneuver if you suspect spinal injury. Inspect the airway for foreign bodies or secretions. So again, yesterday, once you position the airway, you check if it's clear, you look, listen, and feel. So everything is connected in EMS, right? Everything is connected. Clear the airway as needed. You may need to insert an airway adjunct. Went through this yesterday. So based on the patient's presentation, do you need to use an OPA? Do you need to use an NPA, right? Assess breathing. Now, when you position the patient's airway, check if it's clear, look, listen, and feel. If your patient is not responding, simultaneously check for a pulse. If there is chest rise present, you need to determine the rate of that breathing, how fast or slow the patient is breathing. Does it look consistent to you? Is it regular or irregular? Is there muscle use? So can you observe muscle use? And can you see bilateral movement of the chest? Do you see movement on both sides of the chest? So is both sides of the chest moving at the same time? And you will obtain the breathing rate for a patient by counting the rise and fall for 1 minute. If no chest rise is present and there is a pulse, you need to evaluate the pulse. Is that pulse fast or slow? Is it consistent? So does it feel regular or irregular? And is it strong or weak? And you obtain the pulse rate by counting the pulsations for 1 minute. And if the patient is not communicating with you, you go to your central pulse, which is the carotid pulse. If the patient is communicating with you, then you go to the peripheral pulse. That's your radial pulse. So assess breathing. Assess the rate and quality of breathing. If the patient is unconscious, use the look, listen, and feel approach. Check for foreign objects and remove them. If the patient is not breathing, open the airway and perform rescue breathing. And rescue breathing is required if your patient has a pulse but is not breathing. Now, after we have managed the upper and lower airway based on our assessment, the next phase is we will assess circulation. If the patient is unconscious, you check a carotid pulse. If the patient is conscious, assess the radial pulse. Now, apart from evaluating pulses, we need to check for whether or not the patient is bleeding. So we need to look for signs of external bleeding. We can also look for signs of internal bleeding, contact points on the patient. Once there are signs of external bleeding present, we will control that using the dressings and securing these dressings with roller bandages. Assess the patient's skin color and temperature. So when it comes to your circulation assessment, you're checking pulse, you're looking for signs of bleeding, you're looking at the color of the skin and the temperature of the skin. So that's pulse, signs of blood loss, how does the skin look, how does the skin feel. And we're going to look for color changes in the palm. So is the patient palms pale? Is it blue? Is it orange? Is it excessively red? If it's pale, that suggests a circulation problem. You can look at the lips as well. That suggests a circulation problem. If it's blue, that suggests a oxygenation problem, that's cyanosis. If it is orange, if it's yellow or orange, have that type of color, then your patient might have a liver problem or something might be wrong with their kidneys. If it is excessively flush, that could be a sign of infection or an inflammation issue or an allergic reaction problem. So again, for the circulation, you check pulse, you look for signs of blood loss, look at the color of the skin and the temperature of the skin. And that's your pulse point. On the left, it's the pulse point for the carotid pulse. On the right, it's a pulse point for the radial pulse. All right, let me backtrack on that. Right, so repeating the colors again. So for the skin color, you can look at the patient's palm, or you can look around the lips. Anywhere they have mucous membranes, you can also look. Normally, the palm should look pink. If the patient skin color is pale, so if they have pale skin, pale, that suggests a circulation problem. They have a problem with circulation. If the skin color is blue, so if they have blue skin or cyanosis, that suggests that the blood is poorly oxygenated and they have a circulation problem as well. If the skin is orange or yellow, somewhere in between, that suggests that they have a liver problem or something is wrong with their kidneys. If the skin looks flushed, so it look closer to red than pink, and it feels hotter than usual, that could be a sign of an infection. It could be an inflammation issue, or it could be an allergic reaction problem occurring. All right, now description of the skin. Pale, whitish, indicating decreased circulation to that part of the body or to all of the body. Flush, reddish, indicating excess circulation to that part of the body. Blue, cyanotic or cyanosis, indicate a lack of oxygen and possibly airway problems. Yellow or orange color indicate liver problems or kidney issues. And normal, as I said, the skin should look pink. So skin should be pink, warm, dry. All right, now update responding EMS unit. So after you have completed your ABCs, you should know the priority of your patient, right? So is it a critical patient or is it a patient that's stable? And if the patient is critical, you need to relay this information to EMS, who is en route to your location. You have to relay that information. Now, elements of that report that you're going to relay: the age, sex of the patient, their primary chief complaint, what is their level of responsiveness, and what is the status of the ABCs? So age of the patient, gender, chief complaint, are they responsive? Is their airway, breathing, and circulation compromised? This is important information to pass on. Try to perform all 4 steps of the primary assessment quickly as you make contact with the patient. So you should be able to complete a primary assessment within 4 to 6 minutes. And you should be closer to the 4-minute end, because in the field it takes us about, I would say, a little over 3 minutes. And this is not you working by yourself, this is you working with someone, because when it comes to EMS, you shouldn't be working alone. You're not Superman, right? Or Superwoman. So wherever you can get assistance, and what is recommended is at least 2 responders. Some services use 3. Well, in Jamaica, the only place that use 3 responders is the Jamaica Fire Brigade. Every other organization uses 2 responders, but depending on the organization, there are additional members available from a response team. For instance, KFTL, or Kingston Freeport Terminal Limited, they have a occupational health team, and 2 persons working the occupational health, and they are required to respond if there is an emergency on the terminal. But there is a response team available. So if they are responding and they think they're going to need some manpower, they can request members from the response team, which is a part of the security division. So it depends on the organization. When we're talking about ambulance response, it's 2 persons on the ambulance, 2 persons. In an industrial setting, the opportunity exists for other responders to be available, and it should be utilized. The more responders you have who are properly trained, the more efficient the level of care will be that is administered to the patient. Oh, before I move on, so 4 to 6 minutes. So when you're being evaluated, if you're not able to perform a primary assessment within 4 to 6 minutes, you will not be given a pass for your final evaluation. Now, after you have completed your primary assessment, the next phase is history taking. So if the patient is talking to you, you need to have a conversation with the patient. So investigate the chief complaint. That's the reason why the person contacted EMS. Do not allow a conscious patient's comments to distract you. The purpose of obtaining a history is to gather a systematic account of the past medical conditions, illnesses, and injuries. Determine the events leading up to the present medical situation and determine the signs and symptoms of the current conditions. Now, signs are objective. So signs are objective. So a sign is whatever you can see. So whatever you see, whatever you smell, right? Whatever you see, smell, whatever you hear, and what can be measured. That's a sign. Whatever you see, hear, and what can be measured. The symptom is subjective. So this is what the patient tells you. It's whatever they complain of. So it's subjective information. I feel like my chest is tightening up. right? I feel like something is crushing my heart. That symptom, subjective. Question the patient in a clear and systematic manner. Learn the relevant facts, including serious injuries, illnesses, or surgeries, prescriptive medicine, over-the-counter medicines, and herbal medicines, allergies to any medication, food, or seasonal allergies. So we use what is referred to as the sample history, and this is what you're going to use to obtain information from the patient. So we use that. The S is for signs and symptoms, right? And remember, your signs are objective, so it's based on your observation. Symptoms is what the patient complains of. A is allergies. So you ask the patient, are you allergic to any medication or any food or any herbal supplements, right? That's allergies. M is medication. M is medication. So you ask the patient, are you on any medications or are you presently taking any medications? The patient says yes. Okay, what medication are you on and what do you take this medication for? The P is pertinent past medical history. So you ask the patient, do you have any medical issues? Have you ever been diagnosed with any medical problems? Have you ever had to do surgery? Have you ever fractured any of your bones before? Right? That's pertinent past medical history. The L is last oral intake. So you ask the patient, what was the last thing you had to eat? When did you have it? And E is events leading up to. So you ask the patient, okay, what exactly were you doing prior to having the chest pain? What happened? Talk to me. Right? So events leading up to. So the S is signs and symptoms. The A is allergies. M, medication. P, pertinent past medical history. L, last oral intake. E, events leading up to. That's your sample history. The S is signs and symptoms. All right, so obtain a sample history. It provides a framework to ask further questions of the patient. Ask the patient one question at a time and listen to the patient. Listen carefully and use good eye contact. And you need, as a patient gives you important information, if you need to jot down something, write it down. If the patient is unconscious or senile, a family member or friend may be able to help. So if you can't get the information from the patient, what kind of information can you get from family or bystanders or the scene? Communicate this information to other EMS personnel. All right. All right, now once we have completed the history taking phase, the next phase is the secondary assessment. So we have looked at the scene size up. We have looked at the primary assessment. We have looked at the history taking phase. Now we will look at the secondary assessment. Now the secondary assessment is done to assess non-life-threatening conditions. That's the purpose of the secondary assessment. The physical examination helps you to locate and begin initial management of signs and symptoms of illness or injury. Already explained to you what a sign is, already explained to you what a symptom is. Now, if there is trauma to a limb in your secondary assessment, you are going to expose the limb and you're going to look for dots, right? So if there's trauma to a limb, meaning it's a non-life-threatening injury, after you have completed your ABCs history, you will expose that limb and you will look for dots. Dots. That's the acronym. D is for deformities. O is for open injuries. T is for tenderness, and S is for swelling. So dots is for your trauma patients. You can look for dots for patients with medical, especially if it's a situation where nobody can tell you exactly what's happening to the patient. So it can be systematically a systematic assessment. It can be a focused assessment. It can be a full body assessment, which can be done whether the patient is conscious or unconscious. And I'll demonstrate that and explain it more when we're face to face. So full body mean I'm checking the patient from head to toe. So it can be a head to toe assessment, or it can be you're focusing specifically on an injured limb. Now assume that all unconscious injured patients have spinal injuries. Stabilize the head and spine to minimize movement during the patient examination. So if I'm doing a head to toe assessment on a patient, somebody has to maintain the head in a neutral position. Now, a focused assessment is performed on patients who have sustained non-significant MOIs or a responsive medical patient, right? So if it's a localized mechanism, the injury is specific to a limb, then you focus on that limb. If it's a responsive medical patient and they can tell you specifically what's happening, I'm having trouble breathing, then you focus on the respiratory system and the cardiovascular system, right? You will be guided by the patient's chief complaint. Focus your attention on immediate problems. So if there's something that can potentially lead to more serious complications, then you need to address it. In your secondary assessment, you will also obtain your vitals, right? So respiration, normal adult resting respiratory rate is 12 to 20 breaths per minute. Count the patient's breath for 1 minute, check the breathing rate and quality. Already explained that. The pulse indicates the speed and force of the heartbeat. Take the radial pulse for conscious patients. All right. Take the carotid pulse for unconscious patients. When examining an infant, use a brachial pulse. That's the one in the upper arm. I'll show you where to find that as well when we do the face-to-face. Determine the rhythm and quality. So it's rate, rhythm, quality. And for your pediatric patients, you can check the capillary refill, which you're squeezing the nail bed until it looks pale and then release it, and it should take less than 2 seconds to turn back pink. Right? So squeeze a patient's nail bed firmly between your thumb and forefinger until the nail bed looks pale. Release the pressure and count 2 seconds. The patient's nail bed should return to pink in this time, indicating a normal capillary refill. This assessment is to be done for your pediatric population. Can do it for adults, but it's not as important as it is for the pediatric. Blood pressure, not going to be covering that in your course, but anyway, the blood pressure is written as a fraction, as you can see on the slide, 140/90. That's a blood pressure reading. The top number represents when the ventricles contract, and the bottom number represents when the ventricles relax. And a normal blood pressure is considered to be 120/80 or less than that. A low blood pressure would be a patient with a top number that's below 90. That's considered concerning. But we're not going to go through how to obtain that. So blood pressure, systolic pressure is a force exerted on the walls of the arteries as the heart contracts. So it's when the ventricles contract. Diastolic pressure is the arterial pressure during the relaxation phase of the heart. So it's when the ventricles relax and the blood is flowing against resistance in the arteries. Hypertension exists when blood pressure remains greater than 140/90. And as I said, low blood pressure or hypotension is a top number that's below 90. We check blood pressure by palpation or auscultation. That's the traditional way. There's a lot of digital BP cuffs available. Mr. Hawthorne, what exactly you want me to repeat?
Yeah, just the last thing you're saying about the blood pressure and the what is the hypertension thing?
Hypertension is considered if it's greater than 140/90. Hypotension, which is low blood pressure, is when the top number is below 90. So if it's below 90, that is considered to be a low blood pressure.
Okay, got you.
All right. Now, points to note: as we get older, if our bodies are not in good shape, our blood pressure will gradually increase. Right? So just keep that in mind. If our bodies is not healthy, then the blood pressure will gradually go up. If we're in good shape, the blood pressure will be at the optimum range. All right, now skin condition, check for skin color, temperature, and moisture. Normal body temperature is 98.6 degrees Fahrenheit. Normal skin conditions are described as warm, pink, and dry. And we can check the pupil size and reactivity with a pen light. So we examine each to detect the signs of head injury, stroke, or drug overdose. So we can check the pupils, right? And on the right would be a normal pupil. When we shine a light into the pupil is to constrict, right? So once light hits the pupil, it constricts. If we shine a light in the pupil and it looks like the middle one, which is dilated, right? So it looks dilated and one looks normal. This is a sign of possibly stroke or head injury. So when a patient has dilated pupils or unequal pupils, let me not say dilated, because if both is dilated, it can be considered a sign of death. But if one pupil looks normal or reacts normal and the other one looks dilated, that is a sign that the patient may have a stroke or they may have a head injury. Now, the one to the far right, the constricted pupil, if you shine a light in the pupil, in the patient's eye, and the pupil is pinpoint, it looks like a little dot. So it's a pinpoint. If you see that occurring, that could be as a result of opiate or opioid overdose. So it's possible that this patient overdosed on heroin, morphine, fentanyl, oxycodone, Dilaudid. They took some type of opiate or opioid. This is not common in Jamaica, right? So it's not something that's common in Jamaica. It's just, so this is just general information for you. So pinpoint pupils are associated with opiate or opioid overdose. It's a common problem in the States. So that's the pupil reaction. Let me backtrack a bit. All right. So pupil size and reactivity. Determine whether the pupils are of equal size and whether both react when light is shone into them. So both pupils must constrict at the same time. Pupils of unequal size can indicate a stroke or injury to the brain. Pupils may remain constricted in a patient or person who is taking narcotics. And that's the same as me saying opiate or opioids. Dilated pupils indicate a relaxed or unconscious state. Now, the level of responsiveness, observe and note any changes that occur between the time of your arrival and the time you turn over the patient's care to a higher level of personnel. Use the AVPU scale. A is alert, V, verbal stimuli, P, pain, U, unresponsive. All right, now before we go to the reassessment, so let's just recap. The secondary assessment will be necessary if there is no life-threatening conditions present that you can obviously identify. It can take the form of a full body assessment, or it can be a focused assessment, meaning you can look at the entire body or you can look at a body part. You will use your DOTS acronym. So you look for deformity, open wounds, tenderness, swelling. So you're doing a physical assessment of the patient that can take the form of a head to toe, or you focus on a specific limb. Or it can be a system that you focus on if it's a medical patient. Now, apart from doing your physical assessment, you will be obtaining vital signs or rechecking vital signs. The key vital signs that you want to obtain: respiratory rate, rhythm, quality. Pulse rate, rhythm, quality. Skin color, temperature, skin color and temperature. If you have a pen light available, you're going to check the pupils. If protocol allows, you can do blood pressure, but as I said, that's not going to be done for this course. And you reevaluate the patient's level of consciousness. And I personally always start with the patient's level of consciousness and work my way down. So when I'm doing vital signs, I start from the nervous system and then I move down to the circulatory system. So it's nervous system, respiratory, cardiovascular. So I check the patient's level of consciousness, pupil reaction. Then I check rate of breathing, quality of breathing. Then I check pulse, rate, and quality. Then I look at skin color, temperature, and cap refill if it's necessary. So I start from the top, from the brain, the central unit, and come down. That's how I do vitals. All right, now the reassessment. This is the final phase of the patient assessment algorithm. Now, in the reassessment, you're simply repeating your primary assessment. So you're repeating your primary assessment. That's what a reassessment is. So you're reevaluating the ABCs. You're looking to see if anything has changed. You're looking to see how the patient is responding to your treatment. Do you need to consider upgrading or downgrading treatment, right? And you document appropriately. So reassessment, if you need to continue to care for the patient, some parts of the patient assessment need to be repeated. Repeat the primary assessment. Recheck the patient's level of responsiveness and ABCs. Continue to maintain an open airway and to monitor the patient's breathing and pulse for rate and quality. Reassess the vital signs. So observe the patient's skin color and temperature. Reassess the patient's blood pressure if you're allowed to. Reassess the chief complaint. Recheck the effectiveness of treatment. If the patient's status changes, determine whether you need to alter your care. Identify and treat changes in the patient's condition. Reassess the patient. Now, the standard is if the patient is stable, we reevaluate every 15 minutes. If the patient is unstable or critical, we repeat the reassessment every 5 minutes. But you constantly monitor your patient. And remember, you need to document your findings. In your reassessment, you will also provide a handoff report, things that need to be included, the age and sex of the patient, history of the incident, the patient's chief complaint, the patient's level of responsiveness, the status of the vital signs, the results of the secondary patient assessment, if you did it, because you may not do it on every patient. It depends on how much time you spend with the patient. And I always tell students, keep it simple. So when you're giving a report, it is what the patient tell you. So what is it that the patient told you, or what is it that the scene told you, right? And then, sorry, what is it that the patient tells you? What did you observe, right? What did you observe? Based on your observation, what type of treatment was administered? And how did the patient respond to the treatment? And that's it. So let it revolve around that. What the patient told you, what did you observe, what you did based on your observation, how did the patient respond, right? And ensure that you identify whether your patient is critical or stable. All right, so pertinent medical conditions from the sample and any interventions provided. Now, a word about medical and trauma patients. Patients can generally be classified in two main categories: those who have sudden illness and those who sustain trauma. The patient assessment sequence can be used to examine patients who have experienced illnesses, trauma, or both. I already explained that. When examining medical patients, follow the basic assessment sequence. When caring for a trauma patient, perform the secondary assessment before taking a medical history. Very important. So let me read that again. When examining a medical patient, follow the basic assessment sequence step by step. When caring for a trauma patient, once you have done your ABCs, you will go straight to your secondary assessment, and then you consider history. Always avoid jumping to conclusions. Now, in summary, a complete patient assessment consists of 5 steps. Perform a scene size up, perform a primary assessment, obtain a patient's medical history, perform a secondary assessment, and provide reassessment. The scene size up is a general overview of the incident and its surroundings. During the primary assessment, determine and correct any life-threatening conditions. The steps of the primary assessment are to form a general impression of the patient and the environment. Assess responsiveness using your AVPU and perform a rapid scan that consists of checking airway, breathing, and circulation. And once you find problems in these areas, you need to correct them. Finally, after we complete the ABCs, is this a patient that is critical? Is this a patient that is stable? Update EMS. A medical history provides a systematic account of the patient's past medical conditions, illnesses, and injuries to determine the signs and symptoms of the current condition. The secondary assessment of the patient consists of a full body assessment used to assess non-life-threatening conditions. And if it's a trauma patient, after ABCs, we go straight to the secondary and then history. If it's a medical patient, it is ABCs, history, then secondary assessment. If the patient is stable, repeat the vital signs every 15 minutes. If the patient is unstable, repeat the vital signs every 5 minutes. Provide a concise and accurate handoff report to EMS, and it should include what the patient told you, what did you observe, what you did based on your observation, how did the patient respond to your management. That would be the end of the chapter. Question 1. Which of the following steps might be performed during the scene size-up? Anybody know the answer to that? Please go ahead. Go ahead, Mr. Hawthorne.
I think that would be C.
C as in cat is correct. All right. Next question. What is the goal of the primary assessment? Quickly. Not you, Mr. Hawthorne, somebody else.
D.
D as in dog?
Yeah. D as in dog.
All right, that's correct. Question number 3. Interesting question. Yeah, man. Where are the hands? Go ahead, Kerry, go ahead.
Just a wild guess. D.
Promptly transport the patient to the closest hospital. Anybody have anything different? Go ahead, Mr. Walker.
I would say A.
So I hear A and
A, yeah. A. Determine the
all
period.
right. A would be correct. Remember, as a EMR, your management is field management primarily. The only way you will go on the unit or ambulance is if EMS needs your assistance. So identify the priority of transport. Is it a critical patient? Is it a stable patient? And relay that information to EMS. EMS will do transport. All right, we will take a break at this point. We will resume at 10:30.